Welcome to all of you. I'm very happy being able to have another webinar, which is related to women experiences in lead extraction and also to share some experiences. I'm very happy to have Christina with me. We will have some cases where we would like very much to discuss it with you in a very nice manner. So I think we will just start with the first presentation. This is about simultaneous epicardial CIAD systems. I'm a cardiac surgeon, so for me, it's quite not really unusual to work with epicardial leads. And perhaps you may have some, you're a cardiac surgeon yourself, or you may have some very nice contact with cardiac surgeons, which should be able to place epicardial leads as well. So it may be something which you would like to have as well. I will show you some typical patient. It was a 93-year-old male patient. He had a DDDR system implanted in 2005. The last box exchange has been done in September 23. He had a chronic local infection since that September, and he had many attempts of conservative treatment, as you may see in many patients. He was finally admitted at 15th April this year. He was pacemaker dependent. He had a chronic atrial fibrillation, so his pacemaker system was already programmed to from DDD to BBI pacing since many years. He was also having a pneumonia class 3 and many comorbidities like a CABG in 2010, a severe aortic stenosis where no one wants to go for even another TAVI as planned. He had a renal disease with a low glomerular filtration rate of 29 and high rates of renal markers. So in his case, you see also the lateral view. You see here already that the aggregate is quite very close to the skin and also in the lateral view. And this was his ECG, and you see he was completely paced through the whole time. Due to right ventricular pacing, he had a left bundle branch block, which was as large as over 200 milliseconds. So we decided in his case, because he had an obvious perforation of the pocket, you see the dripping here, it was sometimes closed, sometimes a fistula again. It was all related to the incision, which was done in September. And you see also the redness of the skin. There was swelling over there, also local pain, and a general weakness occurred. He had no fever, absolutely negative inflammation parameters, but it was clear it was a pocket infection. And so for the epicardial access, we use the fourth or fifth intercostal space. It depends on the heart rate test. You see in his case, he had an aortic stenosis, so it was quite very low, and the ventricle was quite very huge. And so in the anatomy, most female patients require an access through the fifth intercostal space. There is to be cautious because you have some structures around, especially the phrenic nerve shouldn't be cut. However, the phrenic nerve is normally very far dorsal, so you don't get normally access to the phrenic nerve. However, what you may have really in contact with, if you open up in the thoracic space from the anterolateral access, you may have the left anterior descending artery really quite very close to it. So you have to palpate. You will feel it very easily if you do have the access. Furthermore, you have to care about bypass grafts. If you have an LV aneurysm, it's sometimes impossible to do a proper placement of epicardial LV leads. And also pericardial adhesions may occur and may also hinder you during the access. This is the intraoperative view after the thoracotomy has been done. You see on one hand, we were just dissecting the skin here. Here's the mammary, you see it here. It's as far down to the fourth intercostal space. You hear this is the cutaneous layer, the subcutaneous layer. Here's the muscle. which was quite not too, yeah, it was quite large in his case. And you see also here the pericardium has been already dissected, and you see through the pericardium the epicardial fatty tissue, and you see the distance from the otis side to the cardiac structure is quite really, yeah, it's really nice, accessible in most of the patients, especially if you have dilated hearts. What is really mandatory to do is to place some sutures, and at least 2 sutures to the pericardial space, so that you're able to place this screw-in lead nicely within this space. This was his case, and you see first step was in his case to implant an epicardial VVI system. You see it here. The epicardial lead has been placed to the lateral part of the left ventricle. It's a little bit close to the tip, to be honest. But in his case, we have had some adhesions because of the CABG he has had. We have had to be care really about severe adhesions, and also about the memory artery, which was used as a bypass to the LAD. So it was a little bit limited access. However, we managed to get this lead on the left ventricle. And the second step was to implant or to extract the whole system. You see there's no lead remnant left. We explanted the DDD system completely. And so the advantage of this procedure is that you have a single operation for extraction and reimplantation. So there's no further lead within the vascular system, which is also very nice, especially if you have septic patients. You have a safe and constant pacing during the transvenous lead extraction. And also you have some LV pacing, which in his case was also something to think about, because he was really having some heart failure signs already there. So this is an approach I really like to use in especially elderly patients where you do not want to have a second operation. But this is not only true in pacemaker patients. You can do it also if you have an ICD device implanted. This is a patient. He is really very sick. He's 52 years old. He has had a single chamber ICD implanted in 2016 and CRT-D upgrade in 2018. He was now on full sepsis, and you see also he has a port on this chest X-ray already there. He had lead-related vegetations which occurred already during the TTE, and the sepsis remained even after port explantation. He was not pacemaker dependent. He had chronic atrial fibrillation. The ejection fraction is quite very low, and he has many comorbidities where you think about what to do in any case. So he has a nasopharyngeal carcinoma with lymph node metastasis, and he is really about signed from his disease. Nevertheless, he had really a definite wish to obtain transvenous lead extraction and to have a new ICD system, because he wants to fly back to his home country by plane, and this was his only concern, being able to fly back to his home. And so I was really, I was not very happy about the indication, but he was really worrying about not being able to get back home. And so the decision would be normally, I would say, taken, putting him on antibiotics and just waiting, but he just wanted to have everything. So in his case, we were also going for a epicardial ICD implantation, which means if you have epicardial screen leads, this means that you have normally the epicardial lead, which has a kind of screw. The screw is related to the muscular structure of the heart. And there is normally, as a bipole, a kind of ring at the epicardial side. And this is sometimes the problem of the epicardial leads, and therefore they are known as less longevity or less, less quality in terms of parameters, especially on the long term. But if you put an adapter with IS1 unipolar, IS unipolar to IS bipolar, you can put two screw-in leads in, and so you have two parts with a myocardial part, which come together to a bipolar lead. This is a very nice option to have really very good sensing and pacing parameters, even over the long term. And this is something which we did also in this case. You see that we implanted here two screw-in leads. They have been put together to an adapter, and this was a DF1 connector of the ICD system. Furthermore, we implanted a subcutaneous finger lead. This was a dorsal side. You see, this is dorsal to the left ventricle, and we put the patient, then we put the aggregate into a pocket which was inframammary on the left side. So in his case, the cardiac structures are surrounded like, I would say, a sandwich from the aggregate and the finger lead, and this was working quite very well. The advantages of this procedure is, again, having a single procedure. Left ventricle pacing is still possible, so the CRTD system can be replaced by this, especially if you have atrial fibrillation, which was already present also in this patient. And you have the full functionality of an ICD maintained, also ATP, which is not present if you replace it by a subcutaneous ICD so far. And you have no intravascular lead, which was also very important in his case. So do you have any comment on those epicardial procedures? Perhaps another idea how to proceed as a single stage procedure? I would be very happy to have your ideas. Christina, do you have any idea?
It's a very interesting case, and in this time we are talking about the opportunity for leadless pacemaker with system for defibrillation. It's the strategy for the future. The interesting thing is if proceed in this way when we perform after performing an extraction, or if in some patients it could be a good idea for first line strategy.
Mm-hmm. Yes, I've seen it also in countries where they can't, the patient has to pay for the whole procedure. And so it was also very helpful for them to have just one procedure, which they have to pay. So they are already, they finished their whole implantation and explantation with one single operation. This was very helpful for them. So this is not, I think, something which we have to think about perhaps in our countries, in the European countries, or in the more and the more richer countries, but this is also something which is very nice for poor people. Okay, there's another idea, another comment. Well, if not, Christina, would you like to go further? I think this is quite very nice. If you could just proceed with your presentation.
Okay. Dear colleagues, good morning. I'm Dr. Cristina Esposito. I come from Salerno Hospital. I propose a case that, in my opinion, can offer a lot of arguments for discussion. I present the case of dialysis 68 male patient with permanent atrial fibrillation, coronary artery bypass grafting, who experienced a seed infection. He was first implanted in 2010 with a single chamber pacemaker. Then he was upgraded to CRTD from the same side with the introduction of the defibrillator catheter and a coronary sinus catheter. So we had 3 catheters to be extracted. The oldest one is the passive fixation pacemaker catheter, a coronary sinus catheter, and the active fixation defibrillator catheter. Before extraction, we put a temporary pacemaker. As first step, we started with the left ventricular catheter, since it was the most recent, and because during the preparation of the pocket, we were able to move it back from the coronary sinus by traction. After arming it with an easy self-blocking stylet, we used in first step a short 9F tight rail to get rid of calcification in the subclavian vein. Then we passed to a long 9F tight rail to completely extract the catheter. At this point, we moved to the old and most complicated catheter, the passive fixation pacemaker catheter. Initially, we armed it with LLD EZ, and we used first a 9F tight rail short, and then we switched to the long tight rail. We reached the apex, but due to the fragility of the catheter, it broke at the tip, leaving the dipole in the fibrotic capsule. The pacemaker was successfully removed clinically because the remaining fragment is less than 4 centimeters and does not pose a risk to the patient or to the extraction procedure. Finally, we removed the defibrillation catheter with the active fixation. Since the mechanism was broken, we had to extract it using the exposed screw through LLD EZ blocking stylet, a short 11F tight rail, and then a long 11F tight rail. We always use a combination with the short first and then long tight rail. And the catheter was completely removed, and the procedure was successful. Subsequently, we reoperated the patient for reimplantation phase after 1 week, and we chose to implant an Aveir leadless pacemaker, considering the long lasting of the battery, the possibility of extraction of this device, the previous infection history, and the need for dialysis. Thanks to its active fixation, we were able to position it away from the apical zone where the remaining dipole was located. At implantation, we had an airway of 33 millivolts, impedance of 375, and a threshold of 0.5 volts. And finally, after another week, the patient underwent subcutaneous ACD implantation without complication. I think that it's an interesting case for a lot of points. The first one is that for my experience, it's always better to avoid using passive fixation catheters. As they results in additional complication for the future extracting physician. Second, in this case, we used only mechanical tool, but sometimes the use of laser system could be helpful, especially in very complicated procedures. The third point is the combination of a leadless pacemaker and an SICD could be considered the first choice especially in a particular class of patient like dialysis patients. It's not by chance that in this patient the availability of access is already reduced due to dialysis. Finally, in this case, the combination of two systems has proven to be crucial for patient well-being and safety. Unfortunately, this choice, these are the first cases, but there is not sufficient literature about this. In my case, the patient was a pacemaker dependent patient, and so the combination of two systems about which there is no literature is a very complicated decision to take, and it's important to have sufficient registry about this. Thank you for your attention. I remain available for any further questions or curiosities.
Thank you very much, Christina, for this really, I think, also very important and also very interesting case report. I think this is something we should perhaps discuss. Are there further comments or any ideas from the other colleagues around? Well, if not, I think we have had quite similar cases in the way that we had infected cases where we did want to do something which is not related with further transvenous implantation. So this is something which is, I think, the same in our cases, which we presented now together. And so I think this is quite another opportunity for some patients. I'm, to be honest, sometimes a little bit afraid about putting something also like a micro or like also the Avir, which is now available in those infected cases, because it's known that even those leadless pacing opportunities, they may also get some endocarditis. Did you have some case where you did see an endocarditis in the leadless pacer as well?
I was having a study where we had the dosage of procalcitonin and PCR. And we saw that when procalcitonin is less of 0.3 with a normal PCR, the risk of second infection is zero. but we need a lot of cases because the percentage of infection is low, so we need to increase the number of patients. But the dosage of procalcitonin and PCR sometimes is useful, especially in cases where you need to implant in a short time the patient.
Mhm. Yeah, I agree. Yeah. Another point I was thinking about, you have been used now 4 tools to extract those leads. You were starting with a 9F shorty, the sub-C. You then had the long 9F tight rail, and then you went for the ICD lead to an 11F sub-C and to an 11F tight rail. So to be honest, in my hospital, I'm always asked about costs. So maybe you're a little bit happier, but I have some thoughts sometimes with our administration, and they are really keen on having the costs as low as possible. So I do not see, to be honest, some problem just to take the largest, which I think is the best. To use just from the beginning, you see. So I sometimes also start even with a 13F tight rail in a coronary in an LV lead sometimes, if I do have an ICD lead also on board. So what are your thoughts about, you're just relating your choice of the device to the lead, or did you experience during the extraction some problems with the very small size of the sheath?
I obviously agree with you. It's not a cheap solution to use 9 tight rail with 11 tight rail. I decided in that way because I was very afraid for the pacemaker catheter, and so I chose to use 9F for because for me the extraction was finished when I could put off that catheter. Yesterday, I performed in an extraction with a 45 kilos woman. In that case, when I have a very small patient, I prefer to use small tight rail. And another thing is that sometimes when you use a large tight rail, probably we treat the most soft fibrosis around the catheter. So it could be simpler but I have no sufficient case to speculate about this. But the decision for the tight rail depends on the patient and obviously on the type of catheter.
Yeah, this is also my choice. To be honest, I'm always looking at the pocket side, and if there is already some calcification, then I'm really tending to take a larger sheath, because then you have a massive fibrosis, which you're not able to cut with a tight rail, but also with a laser sheath. That it's sometimes just too tight to pass through. So I tend to take a larger sheath if you have a larger fibrosis. And this is also true if I do have some pediatric patients. Sometimes, even with a pacemaker lead, I sometimes have to take a 11F to take it out. So, and what I've learned over time is, to be honest, also oversizing is a very important thing, especially if you're stuck somewhere. Sometimes it's really helpful, especially if you have ICD leads. if you have an insulation defect, which is just cut through a little bit, if you just then go with a very small device, normally it's really getting very hard to get the lead out. So my recommendation for most of the colleagues is just to oversize a bit more, being a little bit more. Yeah, I'm also, when I started with the procedures, I also wanted to have the smallest hole which I create. But to be honest, I learned over time that sometimes even a bit, it seems to be a little bit more helpful to oversize, at least in some patients where the fibrosis is really very dense. It's extremely helpful. But I fully agree also with your opinion that sometimes the laser may be really useful, especially in those patients where we have multiple leads, where you do have sometimes even problems in the upper venous system to path down, because then you sometimes just grab the insulation or the whole lead um, of the other adjacent leads. And so this is really something which is very helpful as well. So are there some further comments from our colleagues which joined meanwhile?
So far, there's nothing in the chat. The presentation was very clear.
That's perfect. So thank you very much, Christina. So I think we will just proceed. Oops. No, this is the wrong one. I'm sorry. This is if you do too much, if you do have too much on the table, it's not this one. Oops. I'm sorry. Oh yeah, it should be this one. I just have to get back perhaps. Yes, I'm sorry. It's not there. So the next part is about transcutaneous implantation of a permanent lead for intermittent pacing in pacemaker-dependent leads. We have already heard also from Christina that she was just using a leadless device, which is also being easy to implant if you plan, especially in infected patients, and implantation of any device. In some patients, we would like to have, nevertheless, transvenous systems implanted, especially if you have patients where you would like an AV connection. And so it's sometimes also very helpful if you have the strategy to do something in between two operations. This is a true recent story, which is also very recent, was from the beginning of this year. This was a 86-year-old male. He had in 2011 mitral valve replacement, was a biological valve, and a CABG procedure in November 22. He got a DDD pacemaker because of a second-degree AV block. And this year, in the end of January, he was admitted because of a very severe sepsis when the suspect is pneumonia. He was COVID positive and influenza A B positive. Leukocytes have been normal. CRP was really very high. The PCT was already a little bit higher than normal. And the 30th January, the TTE with a very limited visualization of the valves and the lead due to massive dysplasia was performed without anything, which was really suspicious. However, on the 9th February, there was a floating structures on the lead. However, all blood cultures have been negative. So there was a huge refusal to do anything. I will go over these x-rays which have been taken. This is an x-ray of the 21st January. You see it was about 10 days after admission. The leukocytes were normal, but you see it was really going on a huge pneumonia, and he was really with a very severe dyspnea going on the intensive care unit. Everything was done. Also, antiviral medication was applied. Nevertheless, he just had also at the 2nd of February here, this is the next picture, you see here still the pneumonia is going on, and there's absolutely no relief, and he was getting even worse over time. The CRP increased to more than 300 despite the even antimicrobial therapy, so he was really in a very, very bad status. So in his case, this was a picture of the 4th February, even 2 days later. You see, sometimes there is some change of the pattern, but you see in general, it's a really very huge and wide pneumonia going on. There have been now the floating structures on there, and we had a very huge discussion, and I was claiming for getting the pacemaker leads outside. And this was done on the 14th February. So what we did first was a puncture of the subclavian vein. You see it here, it was quite very deep and very medial. Nevertheless, it's a temporary wire which we placed in. So this was not any concern. Alternatively, I took in, at least in former times, very often also the jugular vein, which is also nicely accessible. However, it's a little bit more discomfort for the patient. So second step, we did insert a permanent ventricular lead and had a pacing through the PSA. He was completely pacemaker dependent. Meanwhile, even he had a 3rd-degree AP block. And so we had a very stable pacing through the whole procedure. We extracted the implanted pacemaker system completely, and then we connected the implanted aggregate to the newly implanted lead. So you have to think about several things. For example, biotronic pacemakers switch to unipolar if you just put the aggregate outside of the pocket. And some pacemakers are also programmed to unipolar pacing, and so you have to make sure that you have a very nice contact to the root if you then re-implant and reconnect the aggregate. In his case, we had a Moraxella osloensis. To be honest, this was the first time that I've heard about that germ. But he is known for presenting with a biofilm, so he is really a very nasty bacterium which is covering all the time. You may think that you get a better effect of the antibiotics, then you stop the antibiotics and then they come back because they just spread out to the bloodstream, and now when the antibiotics occurs, they also create another biofilm and grow during those structures. It's really very nasty, and most of those germs are related to CID infections with a sepsis. So in his case, he was quite very unstable even after this extraction. However, it was a second day that he first claimed for having just some water. And we were wondering because beforehand he was about not able to tell anything. So he would put on tracheotomia. You see, it was the 23rd of February. He was still very unstable, but slightly getting better. So over time, there was also a positive blood culture for Enterobacter cloacae. An adapted antibiotic regimen has been started, and there was also some suspicious structure at the mitral valve prosthesis, which was really something which we didn't want to have. Nevertheless, it appeared that the structure was not related to any vegetation. The patient went better by time. You see, it's a little bit better, seemingly on the left side now, with still the temporary pacemaker wire on there. The aggregate is outside, it's fixed on the cutaneous layer, and there's just a draping around. And he was able being mobilized over time as well. So he had an improved general status. And so finally, we were able on the 8th March of 24 to reimplant a full DDDR pacemaker system. On the contralateral side, we extracted the permanent transcutaneous lead without any further problem, because we just inserted a stylet and just removed the lead without any problem. So this was an easy procedure. And now he's really in a very good status. He's really, he had a lot of luck, to be honest. When I inserted the transcutaneous lead first, I didn't think that he would made it, to be honest. It was really an ultimate ratio procedure. However, in his case, it was at least successful, and he is really in a very good shape. He was just here as an outpatient in an outpatient clinic, and so this was very, very, very nice to see him again. So I think that the permanent, the transcutaneous permanent leads for intermittent pacing are really suitable for patients from extraction to reimplantation in CID infections. If you have a patient with de novo pacing indication and the presence of an active infection where you do not want to put in a permanent pacemaker system, and in patients with acute but not necessarily permanent pacemaker indication, which was sometimes present if you have an acute myocardial infarction, if you have intoxications, or if you have a post-operative status where the epicardial leads do not function anymore. So this is at least something which we do quite really meanwhile very often. And what's really very important about this is that you can mobilize the patient in a very nice way. So the mobilization is, I think, one of the main reasons we are doing it, because especially if you have elderly patients and they have to be put on transient pacing for more than 2 or 4 days, and you have to immobilize them, then they get into a very bad status. So you have also very stable parameters, even if you have a longer periods where you have to bridge. And this is sometimes also possible to have the patient really out of the hospital sometime if they want. I know that from the US colleagues, some of them sent them really home, especially in CID infection cases, if the patient is conscious and not delirious, where he is on danger to put his draping away and to remove the system. Then they sent them sometimes home, put them on antibiotics, get them back into the hospital. But to be honest, in those cases here, I just keep them on the ward and wait until the infection is gone. So do you have also used this technique, or do you think this is something really new? I think I did it several years ago already, but I found that some colleagues are really not aware about this technique. Or would you also use it perhaps in an outpatient setting? So these are my questions to you, and I would like to share this. So Christina, you're there.
In the permanent pacemaker implant, why did you decide for a dual chamber pacemaker instead of VDD or a single chamber pacemaker?
He had a second degree AD block. You see, it was this was the lead which we have seen in between. It was just a single chamber as a transient solution. It was clear that he would have to have another DDD system thereafter, because he had a sinus rhythm. Instead of atrial fibrillation, I would have perhaps decided in a different way, but he was having a stable sinus rhythm. But an AV block, and he was about pacemaker dependent.
If you had to choose between pro and cons in the decision to make a second implant with a leadless or a traditional pacemaker. Which are the steps, the decisional step you follow?
To be honest, I think so far the leadless devices are not really suitable or not very good if you have an AV connection necessary, which means if you have a DDD system, which you have to use because of having a constant sinus rhythm, which you would like to maintain, or if you have a sick sinus syndrome, then I think it's really much better to have the conventional system implanted or to have an epicardial solution if necessary. But to have the opportunity to get those 20% of hemodynamics added to the just ventricular pacing. So I think this is one of the main parts which I really like to go. And to be in his to be honest, in his case, which I presented now, he had a long-term infection, and so we put him really for a long-term also on the intermittent system with a temporary pacing. And it was really absolutely not clear whether he would survive it. So it was no opportunity in his case just to replace something at the time where we did the intervention. So, but it may be different if you have a patient with atrial fibrillation, or if with atrial fibrillation and perhaps also the necessity to have a left ventricular pacing, then you should really decide which way you do. I understand that you really like the idea of leadless pacing as a solution after any extraction which is done. To be honest, at least in my experience here, we do have most patients which do have still an atrial function there. So in my series, I mostly replace after a while the conventional system again. And also, I told you with the ICD, epicardial ICD system, which I presented beforehand, it was due to the fact that you may have also ATP available. I know that Boston Scientific is still, I think, since 8 years on its way to present the combination of the SICD with a leadless pacer, so that you will be able to get the full functionality of an ICD, especially ATP. But I think so far it's not on the market. Do you have another idea? Did you have already the Boston system, which is complete with leadless and SICD as a combination?
But I know that leadless Boston can perform ATP after defibrillation, but it's not a pacemaker leadless. So it's far from
the functionality, yes. Okay.
In this moment, we have a leadless that has a long longevity of battery, and I agree with you on the fact that I don't like to put more than one leadless in a patient. So I chose between the patient that are having just one implant, and so when I have a patient not so old, I prefer to choose on the battery longevity.
So you tend, especially in younger patients, you're tending to get another conventional system in. Am I right? If you have a 40-year-old patient with a CID infection and you remove the system, You would go for a leadless, or would you go for a conventional system?
In so very young people, I should not choose for leadless. No, no, no.
Well, because I've heard it from some colleagues which also claim for just getting further leadless phases, perhaps later on in there. But I completely agree with you. I would do it as well. That's perfect. Okay. So any other?
I think it's a very, very useful the case you proposed of an epicardial, in that case, an epicardial instead of leadless. Your
maybe
case is very interesting, especially in this kind of patients.
Yes, yes, yes. That's great. Okay. So any other comments? Do we have something in the chat? Not so far.
No, there's nothing in the chat yet.
Okay. So I think we can conclude that we have had a very nice discussion about several options for patients as an intermittent solution, or if you have especially an infection of a CIED system. Christina presented with the SICD solution combined with a leadless pacer, which are independently working, which I also find very interesting. And it's very nice that it works, because I know that there have been some concerns about Boston, about the sensing, if you have anything implanted which is not related to the ICD system itself. But and we have had also a simultaneous epicardial approach, which we were heading to. And I think there are for sure many questions open. I would like to answer them if possible, perhaps by mail. And I would like to invite you also to the next session, which will come up later on. Michael Douglas from Philips will provide all the information. And I also would like to thank, on one hand, Christina and her colleague. Thank you very much. And also Michael Douglas and his team for making it possible that we could have these webinars available still. And it's much easier sometimes, but getting it in person, but nevertheless, it's very nice to see you. Thank you very much.